Hello friends, I am Dr. Shakuntala Ghosh, Senior ENT Consultant and Director Sri Rama ENT Care Center, Hyderabad. Today I am going to speak to you about a very common and relevant topic, pediatric obstructive sleep apnea, pediatric snoring and mouth breathing. So in 10% children, the snoring and mouth breathing is very commonly seen. And in 5% of those children, obstructive sleep apnea is also known to occur. So what could be the causes of snoring, mouth breathing and obstructive sleep apnea? So obstructive sleep apnea is a severe form of snoring and mouth breathing, whereas in initial stages the child will manifest with a noisy breathing during sleep, or when it is severe even during when the child is awake, and sometimes the child may breathe with the mouth open continuously. So what could be the causes? The most common cause of pediatric snoring and mouth breathing is of course obesity. Obesity is very common in children these days because of the lifestyle, sedentary lifestyle, the irregular physical activity, binging on junk food, the intake of lot of high calorie, carbohydrate rich and fat rich diet, and also because of a lack of physical activity. So obesity itself can lead to snoring, mouth breathing and obstructive sleep apnea. The other common cause for this condition is enlarged adenoid and tonsillar hypertrophy in the preschool and school growing children. So what are the adenoids and tonsils? These are enlarged lymphoid tissues present at the back of the nose and in the throat. So when they are enlarged to more than 50% or 70%, they cause an obstruction of the upper airway, leading to the child having snoring during sleep and also mouth breathing. The other common symptoms will be restlessness during sleep and continuously turning in bed, getting up in between, or lying on the abdomen, or lying on the mother's, putting the head on the mother's lap and sleeping, not being able to lie peacefully in the supine position. And also such children will have daytime symptoms like hyperactivity, attention deficit disorder, then also poor attention span, lack of concentration in whatever work they do or during their studies. So this will affect the school performance in the long term and also lead to a lot of health conditions like frequent upper respiratory infection, leading to breathing difficulty, and also in future it can lead to other complications like adenoid facies. That is, there will be permanent changes in the facial-maxillary structure. They will have a retruded chin, a protruded upper jaw with the teeth which are irregular and protruding outwards, and thick lips, a high arch palate, and also the child will have an elongated facial structure. So this is called a typical adenoid facies. Also such children in the long term, if they suffer from chronic mouth breathing and snoring or obstructive sleep apnea, it can lead to failure to thrive, poor food intake, poor growth and weight gain, and in the long term that can lead to pulmonary hypertension and also cardiac disorder called cor pulmonale. That is why this is a very important condition which should not be neglected by parents. So snoring and mouth breathing in pediatric population should not be ruled out as a normal phenomena. There is an underlying pathology which causes the obstruction in the upper airway, which leads to snoring and mouth breathing. So as parents of such children who have symptoms, who are habitual snorers, that is, who snore for more than 3 times a week, even when they are not having episodes of cold, or even when they are not having a runny nose or throat pain or fever, such children should be brought immediately to a pediatrician or an ENT specialist for proper evaluation. So how do we assess such children? So first of all, we look out for obesity. So we calculate the weight and the height of the child and calculate the body mass index. A BMI of more than 25 is considered as abnormal, that is an obese child. So such children need to be properly treated evaluated by an endocrinologist to rule out any underlying hormonal disorder like hypothyroidism or any other issue, and they should be treated also by the pediatrician. A proper dietary advice should be taken from the nutritionist, and then the child's diet should be monitored. To lose weight, he should be encouraged to do physical activity also, some kind of an exercise or a hobby which includes cycling or some kind of a physical activity in terms of some game, etc. daily for half an hour to 1 hour. That will keep the child active and help him to reduce weight. Secondly, we do a thorough ENT examination. We look for any deviated nasal septum, turbinate hypertrophy or polyps in the nose. Next, we do nasopharyngoscopy. It can be done with a pediatric rigid endoscope or with a flexible fiber optic endoscope to assess the size of the adenoid. Adenoids are present at the back of the nose, above the soft palate, and it is basically a lymphoid tissue. Normally, it will be occupying the nasopharynx posterior wall, but when it is enlarged to 50% or more, it will fill up both the posterior choana and the child will not be able to breathe through the nose. So that is, has different grades: grade 1, grade 2, grade 3 and grade 4. Next, we open the mouth and examine the throat to look for any tonsillar hypertrophy. So tonsils are also lymphoid tissue present on either side of the uvula in the throat. So they can be enlarged, and sometimes they will be more than 50% enlarged, sometimes 75% enlarged, and sometimes even 100%, so that both the tonsils meet in the center on either sides of the uvula and there will not be any gap in the oropharynx. So based on the size of the tonsils and adenoids, we can grade it as grade 1, 2, 3 or 4. Grade 3 and 4 are considered as severe adenotonsillar hypertrophy, and they contribute significantly to obstructive sleep apnea. So once we have diagnosed this cause, which is very common in even 10% of children, in that case we have to treat it. So initially is medical treatment. A course of antibiotics, antihistamines, nasal decongestants and intranasal corticosteroids are given. So the corticosteroids are given for 1 to 3 months, and that is mometasone spray is given intranasally to the child. And sometimes the children will improve with these medications, and the child will able to breathe freely through the nose, and the mouth breathing will also reduce, and the child will have a peaceful sleep. Sometimes when the adenoids and tonsils are very enlarged in size, that is grade 3 or 4, there will not be any relief of symptoms with the medical management even up to 3 months. In such case, the child has to be subjected to surgical treatment. That is called as adenoidectomy and tonsillectomy. So what are the various methods of doing the surgeries? We can use cold steel instruments or microdebrider or bipolar diathermy, and the latest is of course the coablation adenotonsillectomy. So I personally prefer the coablation tool because it is a very safe tool. The heat generated is very less, and precise dissection of the adenoids and tonsils tissue is possible without any blood loss. The recovery time is very less, and the child will be able to have normal diet and become active and join school within 1 week to 2 weeks time. So that is called as coablation adenotonsillectomy. By this method, we can reduce the size of the adenoids and remove the tonsils completely, so that we can clear the nasal and the oropharyngeal airway, and the child will have a peaceful sleep at night through the nose and without any mouth breathing and without any snoring. It will also reduce the chance of obstructive sleep apnea and its complications in future. Thank you.